Hi, this is Sakib Rahman from the OrthoClips Podcast Series. And today we're going to be talking about DOACs and hip fractures. Should we wait 48 hours? I'm going to be speaking with Devon Brameier, who's a senior clinical research coordinator in the Department of Orthopaedic Surgery at Harvard Medical School Orthopaedic Trauma Initiative at the Brigham and Women's Hospital. And she's the first author of the paper entitled Use of Direct Oral Anticoagulants Among Patients with Hip Fracture is Not an Indication to Delay Surgical Intervention. And this was in the March Journal of Orthopaedic Trauma. I think it's a great topic. Thank you for coming on the podcast. Appreciate it.
Yeah, thank you so much for having me. I'm really excited about this opportunity to talk about our paper.
Great. And was your paper also presented at the Academy this year?
It was. So it was presented both
Yes.
at OTA and at the Academy this year.
Yeah. I missed OTA this past year, but I was at the Academy and I believe I was in your podium session. I was in the scientific session for trauma papers. And I think there was another paper from the Cedars-Sinai group on a similar topic that they grouped with yours. We can get to that. Why don't you first tell me, how did you get interested personally and involved in this study? How did the study come about? And, how did you particularly get involved? If you want to just discuss that.
Absolutely. So I got involved in this study as part of my role as the clinical research coordinator for the orthopedic trauma team at the Brigham and Women's Hospital. So within that role, I'm involved in a number of different studies, both from the design side, and on this one, I came in both for data collection, analysis, and manuscript writing. This particular topic was a real interest point for our group because we're very cognizant and aware in our own patient population how the increasing age is getting more and more of an issue, and we're seeing a lot more hip fractures. And we're also seeing much more medically complex patients. And among that, we're seeing a lot more patients on anticoagulants. And there was really no clear idea or decision of how should we be treating these patients. Should we be waiting to discontinue their anticoagulation before we operate, or should we be operating early, as we know that early operation in these patients leads to much better outcomes in terms of morbidity and mortality. So it was a bit of a hot button topic. There were a few studies that had been done on this topic prior to us starting it, but at that time, most of those were just comparing anticoagulated patients to non-anticoagulated patients. And the ones that did look within the anticoagulated population specifically were still relatively small. So we realized that within our trauma initiative, which is a joint collaboration between the different Harvard affiliated hospitals in Boston, we had the potential to make a much bigger patient population that we could hopefully draw better conclusions from.
So maybe it's important to clarify anticoagulation because there's different types, right? I mean, there used to be lots of patients on warfarin. Then you had low molecular weight heparins, things like enoxaparin. So what are we talking, antiplatelet agents also. So here we're talking about what specifically?
So we were talking about specifically direct oral anticoagulants. So these are your apixabans, your rivaroxabans. They are acting specifically on 10A inhibitors. And so this is a medication that has grown in popularity, particularly in the last decade or so, as it's been shown to have much more favorable drug interaction profiles compared to warfarin. It also requires less monitoring, so it's favorable both from a healthcare provider side as well as a patient side. But part of the problem is that there are reversal agents, but many of those are prohibitively expensive. So whereas we had methods that were known as to how to manage the discontinuation in a patient on heparin or a patient on warfarin, it wasn't yet clear what was the best way to handle these patients who are on these direct oral anticoagulants that really are at least we thought, a more increased risk of bleeding if we operate too early.
Okay, because if a patient's on aspirin, I think we have some data that suggests that probably shouldn't wait 7 days and it's probably okay to operate. And I think maybe that was a little bit of a easier question because it wasn't like you were waiting 48 hours. The question was, I mean, are you actually going to wait 7 days? And people really weren't doing that. They're saying, well, it's a hip fracture. We're not going to wait 7 days for, the antiplatelet effects to go away. But with this, I think, a lot of centers are saying that we have to await this washout period, so to speak, where the direct anticoagulant that you cannot reverse needs to be sufficiently out of the system. And you also can't really measure like you can with INRs very readily. So it's a conundrum. I mean, you have patients come in and you're saying your hip fracture protocols say that you got to get to them within 24 hours ideally, and they're otherwise ready to go. But then you're like, wait, they might need another day or so because they were on a Pixaban. So tell us about your study design, how you set this up, and your results.
Absolutely. So we set this up as a retrospective cohort study. So this was conducted, as I said, at 3 different level 1 trauma centers in the Boston area. And we were specifically looking at patients over the age of 65. And we wanted those who had been on consistently a direct oral anticoagulant prior to their hip fracture, and then were managed operatively for their hip fracture between the period of 2010 to 2018. And we did exclude patients who had their last dose more than 24 hours prior to admission, as that made some of our time calculations more challenging and less accurate. And then we also excluded those who had a polytrauma accident and those who were delayed to surgery for reasons other than just their direct oral anticoagulant. So a lot of that was specifically through chart review, determining whether or not patients were excluded or delayed to surgery for maybe a medical optimization issue rather than just waiting for that direct oral anticoagulant to wash out of their system. So this was a chart review study. We specifically were looking at a number of outcomes. One of the main ones was just the complication rate. We were looking at whether there's any difference in the rate of deep venous thrombosis, pulmonary embolus, wound breakdown, drainage, or infection, things that we thought would be much more closely tied to an increased risk in bleeding if someone is anticoagulated at the time of surgery. We also were looking at their transfusion requirement as a measure of their bleeding, looked at their estimated blood loss within the procedure, and then we also looked at length of stay, reoperation rates, and mortality. So with that said, we had 205 patients. So it was the biggest study that's been conducted in this patient population. Again, all of these were above the age of 65. We had an average age of about 82 years old, and it was a little over 60% female population, which is to be expected in this hip fracture population. Is what we do see. There were no difference in our demographics between the 2 groups of those that were treated early, and we defined early treatment as within 48 hours of their last preoperative DOAC dose. And there were about 71 patients who were in that early group, and we had 134 patients who were in our delayed group. As I was kind of alluding to, there was no difference demographically, but there also was no difference in the complication rates between the 2, which was really striking to us. And actually, there was an increased transfusion requirement in those patients who were treated delayed. So a bit opposite to what we were expecting when we were going into this study, but really interesting to see. And the more we thought about it, it made a lot of sense. You're fixing the source of bleeding, which is the fracture earlier, and thus probably stabilizing that patient and their hemodynamics much quicker while they are still anticoagulated rather than just waiting for their surgery.
And maybe clarify, in case I just kind of missed this, how did you believe the patients were selected? And of course, it's a retrospective review, but looking back, was there any indication why a patient was treated, in that early group versus the late group?
So in terms of the late group, it typically was just within the kind of consult note of the orthopedic team that the decision was made to wait 48 hours from their last dose at a minimum. So if their last dose was the day before they came in for admission, then the note would say wait 2 days, and then we would operate. There was as you said, this was a retrospective chart review based study. And so it was difficult to get exactly what was the thought process behind the surgeons at that time of making that decision. And in the early patients, there was no explanation as to why they were deciding to just go straight to surgery earlier. That just seemed to be the decision that they made. I can't remember if there was a difference in terms of the timing of as we got into the later years, there being more patients who were treated early. But it was hard to determine exactly what was the reasoning behind these surgeons and their decisions.
Okay, so it was not clearly like, surgeon preference where you knew that, there were certain surgeons that were always saying you had to do it one way or versus the other. And this involves multiple centers within your
Yes.
group, right? Yeah. Um, so what's been, I mentioned at the start of the podcast, I saw your paper at the Academy meeting podium, followed by another paper from another center looking at a similar topic. And what did you feel was the reception at the OTA, at the Academy? What are other people saying about your study? What about other clinicians at your institution, medical and surgical teams who also have to manage these patients, anesthesiology, your institution, and then, reception elsewhere. What are you guys hearing about this?
Yeah, absolutely. So I think we've been really thrilled with the reception that we've had. So we had a really great experience presenting this at the OTA and also at the Academy. Some really great questions were asked. And I think, at least from the conversations I've had with the various surgeons I've met at different conferences talking about this study, it was a bit of a relief to many that they could feel comfortable in operating on these patients early, that the biggest hurdle many of them felt they were facing when it came to these patients was actually some of their medical colleagues, so particularly anesthesiology, being more hesitant to operate early. And so many surgeons felt like this gave them the data to bring forth to their colleagues to say that this is safe, that we're not increasing the risk, and actually we might be improving the risk profile for these patients if we do operate on them earlier. Within our own hospital systems and the ones that were part of this study, since these results have come out, we are not delaying patients just because of them being on a DOAC. So they are treated in the normal fashion of aiming to get them fixed within 48 hours. Obviously, many of these patients who are on DOACs are very complex medically. And so there are some patients who have other reasons to be delayed. And so it really does require close collaboration with your medical colleagues and with your anesthesiology colleagues. But if there is no other reason that's hindering you from going to the OR as promptly as you can, we really advise that you should consider that in this population.
Um, okay. That's good to hear. Okay, I mean, like I said earlier, this is definitely a problem where you have this conflict. You want to get to the surgery early, but you don't know what you're gonna get in terms of bleeding. Are there different doses when it comes to DOACs, where you kind of might need to be more worried than not? So I'm just thinking the corollaries being, let's say, warfarin. I mean, sometimes you would sort of do like a low dose warfarin where you're aiming for an INR of maybe, 1.5 to 2 or something like that, as opposed to someone coming in who they're aiming for 3, but they really come in at like 4.5. I would say
So
most surgeons probably aren't operating on someone if they know their INR is 4.5. And whereas if it's 1.5, they probably are. Now, we don't have that information. We're just saying they're on a DOAC. So is there any nuance to that we should be aware of, dosing or otherwise?
so given the size of the patient population, there was also a decent spread of different types of DOACs. And I think that is another thing to consider. There are a few different DOACs within that family, a few different drugs. And so we weren't able to break it down to the dose level. But we did notice some trends and things that I think actually require further investigation. So we were mainly focused on the timing of surgery as related to just being on this medication. I think next steps is looking at, is there a dose dependent relationship and the impact of these drugs on our patients. But we also, I think, need to try and repeat this at a bigger size to look at the different DOACs themselves. We did see a difference in the mortality rate specifically of patients who were on dabigatran compared to rivaroxaban and apixaban. We had a fairly small group of patients who were on dabigatran, so it's unclear how significant that relationship is, but I think it is something that needs to be investigated. So can't unfortunately comment on the dose relationship specifically for these patients, and I think that is something to think about and really consider, but it also is something that warrants further investigation.
Yeah, on that note, any other specific further investigations do you think that would be the most logical next step? Is it that? Is it something else that would be maybe a future investigation to follow up on this?
Yeah, so I think that's definitely the big one that jumped out to us because it was one of the findings that we didn't expect to see. So I think going and exploring, is there a particular DOAC that maybe is higher risk, or are they all similar risk at a larger scale would be very useful to have. Um, I also think, you know, we were looking at this and we hadn't actually considered the anesthesiology approach, or the anesthetic approach. And I know that many anesthesiologists, if a patient is on a DOAC, they will not do a spinal. It is a direct contraindication. And that was something we didn't include in our original analysis. So if we were to go back and repeat this, I think that is something that we would also include is what kind of anesthetic was chosen for that patient and how did that interplay? Is it that many of our patients who were delayed were planning to be given a spinal and so they had to wait, or is there something else at play here?
Yeah, a lot of things to think about that I think you or someone else could consider investigating further. I, like I said in the beginning, I think it's a really important topic, and congratulate you guys on your contribution to this. Um, the just to kind of sum things up as we wrap up, I've been talking with Devon Brameier, who's from the Brigham and Women's Hospital, about our topic, DOACs and hip fractures. Should we wait 48 hours? And sounds like the answer is probably not. Their paper, Use of Direct Oral Anticoagulants Among Patients with Hip Fracture is Not an Indication to Delay Surgical Intervention, is in the March 2024 Journal of Orthopaedic Trauma. So thank you so much again for coming on the show. I really appreciate it.
Yeah, thank you so much for this opportunity.